on this episode of A Tale of Two Hygienists.
Better safe than sorry is not the way to be going about antibiotic prescriptions. We have seen a growing resistance to antibiotics worldwide, and it's really a concern. When you look at some of the CDC facts, there's over 2 million people in the United States who become infected with an antibiotic-resistant bacteria a year. If we can be educated, what are the current guidelines? Why does your patient no longer need a pre-medication? If they've taken it for 20 years and now you're like, oh, you don't fit in those guidelines. If you can have an honest conversation with your patients like, we know better. We don't want to continue practicing dentistry the way we've practiced it 20 years ago. We know better. And so my job is to give you the current scientific evidence. And I think those conversations make such an impact on your patients.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 438. I'm your host, Andrew Johnston, and thank you for joining us today. In this episode, we are joined by Sue Scherer, and we talk about a lot of things antibiotics. So we made a list of the controversy of when to use it, when not to use it. We talked about the different types of antibiotics to use. We talked about the responsibility that we have as providers to make sure that we're checking with our patients before all of their appointments. We talked about so many things. Sue is a wealth of knowledge. I'm so excited to have her back again in the future, but you're going to love this episode. And then next week, we have an episode with Annie Walters. Annie's the new co-host for A Tale of Two Hygienists. And we kind of dive deep into who she is. It was an interesting pairing, kind of how we came together as co-hosts. And I didn't really know her all that well. And so it was fun for me to kind of explore and kind of learn her personality type, because even in our side conversations, it's very, kind of high level professional stuff. And so it's hard to know what her opinions are on things because she's being very professional. And so I'm so lucky because she kind of opened up a little, and you can kind of see into her soul a little bit about what she believes and how she thinks and all of that. So it's really fun getting to know her. So make sure you come back next week for that. In the meantime, make sure you hit that follow button or that subscribe button. And that's it. That's it for this intro. I hope you all enjoy this episode with Sue Scherer.
A tale of two hygienists.
Welcome everyone into the interview portion of the podcast. I'm joined today by Sue Scherer. Thank you so much for being here, Sue.
Thank you for having me.
You know what? I'm really excited, Annie. We have Susan talk to us about antibiotics. It's a topic where I'm like, we need to have this conversation over and over and over again, yet no one really wants to have the conversation.
Yep.
Yet all the Facebook groups pose the question in the groups. So I'm excited about it, but I don't even know how to feel about it. How do you feel about it, Annie?
Yeah, same. I feel like this is just a constant, swirling topic that we just go round and round and round and talk about. And yeah, there's just a lot of different feedbacks and schools of thought. And so I'm really excited to dive into the research aspect of it as well.
Yeah. So the impetus of this, and Sue, the reason why we reached out to you is just, you wrote an article in RDH magazine that kind of outlined this. So I'll link to that in the show notes, everyone. If you want, something to look back to as a reference, I'll link back to that. But at the same time that I had come across your article, actually Tanya Dunlap actually posted on LinkedIn. And so I came across it there. And then there was a thing called, I'll link to this in the show notes too, is a video on YouTube called, I want to say it's like Ask the Doctors or something. And I want to say it was a cardiologist, or maybe two cardiologists, or maybe an ortho and a cardiologist, I'm not really sure. But two MDs, and they were talking about this very specific topic. And I'm like, all right, universe, keep hitting me over the head that we need to have this on the podcast. So we have lots of questions for you. Are you ready for this?
Well, I think so.
Okay. So I think the first question that I want to kind of get into is, we've had throughout my career, probably your careers as well, this antibiotic thing, whether we should be doing it or shouldn't be doing it, has changed back and forth. And it's almost like to the extreme poles, right? It's like never do it or always do it. There's not really a lot of in between. So I kind of wanted to just know like your history with what you've seen since you've been practicing.
Yeah, so that was a big issue for me clinically when I was, chairside, and I was chairside for 20 years as a hygienist and 5 years prior to that as a dental assistant. So I really saw that this was a common concern that would pop up for dental professionals, and how many times I would run in. I worked with a really fabulous doctor for 18 out of my 20 years. And I would always be like running in like, hey, this changed on the medical history. Is this a concern? And there's definitely a lot of confusion that circles around that. And I do believe it's because of the changes that have happened over history. But if we look at the history of pre-medication, pre-medication for prevention of infective endocarditis came about in the late 30s. And then when you look at that in the 40s, they finally gave regimens. And if you go historically over that, there were changes. There have been changes throughout time. And I would hope so, right? 90 years has passed since we started this practice. We're creeping up on almost 100 years of that practice. Things should change because we should be learning and we should know better. But personally, I will never forget 2007 when mitral valve prolapse and heart murmurs were removed. That reduced the number of patients that were pre-medicating by 80%. And so when you think about that, I remember being ecstatic, right? And thinking, oh my gosh, what a relief for all the people that would forget to pre-med, and personally, that kind of meant maybe, patient was going to be dismissed, and I was kind of happy because now I had a little time to run to the restroom and eat a snack and all those things.
Yeah.
But we know differently now and can certainly talk through what that looks like. But, there is this history that has left confusion for people. And beyond infective endocarditis, the bigger, I think, confusion point for people has been prevention of prosthetic joint infections. And what has happened with that is that the ADA and the American Academy of Orthopedic Surgeons didn't always see eye to eye on what the science was. And so they've really come a long way since that was the recommendation began with prosthetic joints for all patients that had a prosthetic joint replacement. And that was in the early 70s. So we saw in the late 60s this successful joint replacement surgeries taking place in the United States. And so what does that lead to? Now it leads to an increase in the number of surgeries that are taking place. And all of a sudden they start seeing infections of prosthetic joints. And it's kind of like, okay, well, we have this hypothesized mechanism of thought on what is causing the infection, right? And so the key word that you hear there is hypothesized. There was no evidence to support this practice for the prevention of prosthetic joint infections. And that practice has been carried up into really 2014, which is when the recommendations for joint replacement was changed for antibiotic prophylaxis. So, it's interesting. And it's not those aren't our professions, right? We're not cardiologists. We're not orthopedic surgeons. And so we try to go by the guidelines we have. But if those on the outside of us aren't following that, it makes it harder to understand what we should really be doing.
I remember 2007. So 2007, sorry, listeners, that's when I started my education. So the change had come about, and we were in that, you were talking earlier, I can't remember if it was on or off air, but about how you were kind of in the middle of this change with your program. We were in the same one. It's well, boards are still expecting this answer. You still need to put this on your boards. However, in practice, don't do this. Right. And so it's so weird. And then I remember 2014 was, for me, did you guys ever do Dental Town or Hygiene Town?
Oh, yes.
I don't think I did.
Not so much. So,
yeah.
It was basically I would say job board, but it wasn't a message board. There we go. A message board that had if you had a question as a hygienist, you go to Hygiene Town, you pose your question, and everyone can answer. But it's it's broken down by topics and categories. It was awesome. It was before Facebook had groups, really. And I remember in 2014, that was kind of the big thing, especially on the Dental Town, on the dentist side, was this huge uproar about well, I've always done it this way. I'm going to go ahead and keep doing it that way. No one's died because I gave them an antibiotic and all of these things, right? They're really staunch. They never wanted to change. Two key integral dates that I'll never forget around this history. But I want you to talk a little bit about that thought process though, where the doctors are saying like, look, we have always done this. We're not really hurting anybody. Is that, is there any validity to that?
So I like to say, right, it's that better safe than sorry attitude. And better safe than sorry is not the way to be going about antibiotic prescriptions. We have seen a growing resistance to antibiotics worldwide, and it's really a concern. When you look at some of the CDC facts, there's over 2 million people in the United States who become infected with an antibiotic-resistant bacteria a year. And I don't know about you, but I don't want to end up in the hospital with an infection that is resistant to antibiotics. Like, I want to go and then be able to treat me and give me what I need. And so for me, that was startling. And I think it's like something like 35,000 people die a year from antibiotic resistant infections. And I think about, I don't necessarily associate that with dental, right? But I think about MRSA and things like that. And the point becomes, if we are taking antibiotics when we do not need them, the bacteria, they figure out that antibiotic and they change. And so then they resist when they're needed. And that's the problem. If we are taking antibiotics unnecessarily, then there's a chance that they won't work when we need them to. And so I can only speak personally, right? I want them to work when I need them to work. And so if that mindset is better safe than sorry, and you're taking it when it's not needed, you're growing the chances that when you need it, it might not work.
Do you think I think speaking from experience too, and working with other dental professionals, there's almost like a fear associated that if we don't give this patient an antibiotic, and if something were to happen to their joint, and then it's on us and on our license, it's just like this fear. And I think that's, I don't know where maybe some of that like better safe than sorry comes from, but also at the same time, is that mindset purely just professionals not being aware of the evidence-based research behind it?
I think it's legitimate concern, but when you flip it around and you say, what happens if you give the patient antibiotics when they don't need it and they do have an adverse outcome? What if they've never had an anaphylactic reaction and now they take a medication they've never taken before and they have an anaphylactic reaction? So when you take antibiotics unnecessarily, even if it's if it's a gastric upset, if a patient ends up with C. diff, for example, C. diff is highly contagious and it is very hard to treat. So you can't just treat it with a broad spectrum antibiotic and it goes away. It's usually a long-term course of antibiotic therapy. It's an infection of the colon. And there's correlations when you dive into the science. There's correlations connecting C. diff to potential for Crohn's disease. And, there's a lot of outcomes for that. So if you have a patient that every time they come in, they take an antibiotic that they don't really need to take in as a pre-medication, and it's leading to gastric upset, what's the potential risk there, So there is a flip side to, if you're giving an antibiotic to a patient that doesn't fit into the guidelines, isn't that a risk,
Absolutely. And I think, I want to talk a little bit about that antibiotic stewardship now, because we're talking so much about needing to be aware of, giving antibiotics unnecessarily. And so how can dental professionals be better stewards around antibiotics, and kind of what is the guideline recommendations? How can we support dental professionals in that space?
Yes. So that's a great question. And it's really following the current guidelines is one of the best ways we can do that, and not prescribing unnecessarily.
Sure.
I remember my kids being really little and they'd be sick. And I was a working mom. I've always been a working mom, right? So your kids are sick, they're out of school, and you kind of hope you go to the pediatrician and they tell you that your child has an infection, because then they can prescribe antibiotics and in 24 hours, your kid's going back to school, right? It sounds horrible, but it's the reality. And people think the same with dental, right? Oh, we'll just give them an antibiotic and everything will be okay. We're covering all our bases. But that's not the case. We need to know that the patient has an infection, right? We can't be giving it for viral, and we certainly shouldn't be giving it if they don't have the high risk categories for, that fall into who I should say we are pre-medicating for. So we really have to be mindful, things like even endodontic infections, if they don't show signs of spreading, we should not be prescribing antibiotics. And I say I'm not a dentist, I cannot prescribe. So those who can prescribe should not be prescribing. They should be treating that endodontic infection, because the antibiotic can't reach the necrotic tissue. And so it's not serving a purpose. So that needs proper endo treatment to be cleared. And if the patient shows signs that the infection is spreading, right? If they have a fever, if they're showing other signs, right? Any swelling or, whatever you could think of that could potentially be part of an oral infection, then they should have antibiotics because now they clearly have an infection that's spreading and could lead to other concerns. But really it comes down to, knowing what the patient, right? What is their overall health? What other pre-existing conditions does that individual have? If they're an uncontrolled diabetic, they might need an antibiotic because of their susceptibility to infection and their inability to heal wounds efficiently. Where's that infection located? And again, has it spread or hasn't it spread? And, how can we treat this? Can this be treated some other way other than antibiotics? And if so, then to treat it that way. Those are steps that we as dental professionals can be taking in really having antibiotic stewardship.
I feel like, I don't know, I'm just trying to get in the mind of a hygienist. I feel like there's going to be some out here that are like, okay, look, see, that was all very cute and stuff, but like, that's for the dentist. Like, so what more can we do? And then also like beyond us. So we have our front office staff that has some responsibility in this as well. We have dental assistants that have some responsibility. We have other people in our office. We have the patient themselves. Like, what is their role in this stewardship as well?
I think it's to be educated on the topic, truly. Because think about it, how many times as a hygienist have you told the patient something and you've really kind of given them a heads up? The doctor comes in, they sit down with the patient, they say the same thing, almost verbatim, right? And the patient's like, okay, they feel secure because the doctor wasn't in the room when you shared that information. So if we can be educated, what are the current guidelines? Why does your patient no longer need a pre-medication? If they've taken it for 20 years and now you're like, oh, you don't fit in those guidelines. If you can have an honest conversation with your patients, like, we know better. We don't want to continue practicing dentistry the way we've practiced it 20 years ago. We know better. And so my job is to give you the current scientific evidence. And I think those conversations make such an impact on your patients. But as a team, everyone has to be on board. So you mentioned front desk, right? Or the dental assistants. In the office that I was in for 18 years, it was our receptionist that was the one that called in, refills. And so that individual needs to be knowledgeable too. Or if the patient calls and they have a question, they're educated professionals as well. They might not be licensed professional, but they are a part of the team and they need to be knowledgeable also.
On the Ask the Doctors, I think that's what it was called, is whatever the video that is in the show notes. You mentioned the front office is calling in the script. So they also answered the question, like, who should be like fulfilling the script for antibiotics? What is your take on that first before I tell you what these doctors said?
Well, I like the perspective of the American Dental Association. So the American Dental Association says when it's appropriate, the doctor who's recommending pre-medication should be the one that's prescribing. And so I think particularly about prosthetic joints, because the predominance of patients should not be pre-medicating for a prosthetic joint replacement. So I think we should follow in those cases what the ADA is saying, that it really should be the orthopedic surgeon, the cardiologist writing the prescription. And if their recommendation isn't falling in within the current guidelines and you cannot get further information on why they are making this recommendation, they really should be the one filling and refilling that prescription. So, calling in, making the phone call to the pharmacy, if the patient fits in the categories, and we can certainly break down the categories and talk about those. If the patient fits and the office is comfortable, like, yes, absolutely, you are a patient who needs to pre-medicate for life by the current guidelines, then by all means, the dentist can fill that prescription for them and the receptionist can call it in. But if it's not falling into those categories, and as the dental professional, you're feeling skeptical, shall we say, about that recommendation, then I think it should be put back on the person that's making the recommendation.
And it makes a lot of sense, right? I mean, if we're just going to be like regular human beings, like we're practical people. If I am a cardiologist, I'm trying to protect the work that I did, right? I would be responsible for writing that prescription for someone else on behalf of somebody else. the dentist, I don't think it's the onus of the dentist to make sure, I mean, it is to keep us healthy and stuff like that, but it's really the onus, I think, of the person that is trying to protect the work that they did, because they have a responsibility to clearly communicate the risks and all of that and treatment for the patient. These doctors, however, said, have your dentist do it. We're too busy. Literally, that's what they said. We have too many patients. We can't write scripts for all of them. Literally, that's what they said. So,
well, I would think that those patients would be patients of record of them, that they are, I mean.
Yeah. It should be so easy.
Yeah. Oh, that's.
And I love the beginning of your article too, how you were, because we can all relate to that scenario of running around trying to get in contact with the surgeon or whatever the case may be to try, we're just trying to do the best we can. But here we are, we have these doctors that are like, oh, just have the dentist do it. And it's like, we're just trying to figure it out.
Yeah, I mean, in my personal opinion, right, that's a lack of respect for the profession. I think, I don't know.
We have all the time in the world in the dental office, you guys. Like, I don't know what you're pretending. Like, we don't have time.
Those were inevitably the appointments where you end up, you've lost half the appointment. And now you're like, oftentimes the patient really was clear and it was okay to proceed with treatment. And now you're like sweating it out because you're trying to provide care because the patient has been patient and waited for you to, feel comfortable to proceed without pre-medication. Or you have to dismiss them and they're ticked off at you, right?
Yeah.
Yeah.
Let's come back to like the C. diff conversation and clindamycin, because this is, I think, a relatively, it's not a new revelation, but I think it's very hotly talked about nowadays, if you don't mind going into that.
Yeah, I think it's interesting. So I present this topic quite often and have been for about 2.5 years. And the clindamycin part throws a lot of people off. And so, we all, I think as dental professionals, hear the word clindamycin and we're like, oh, they must be allergic to penicillin. They're allergic, and it's just an automatic association for us. But clindamycin is no longer recommended for our patients who are allergic to ampicillin, amoxicillin, penicillin, however it's worded. And that's because one dose of clindamycin has the equivalent risk of C. diff as a prolonged course. So when we think about, right, I think back to that better safe than sorry. You give your patient 2 tablets of clindamycin, right, and now they have a C. diff episode with just 2 tablets. Their risk of that is just the same as if they took it for a prolonged course of 7 to 10 days or longer. And so we don't want our patients experiencing that, because C. diff itself it has so much risk for, first of all, being able to get rid of the infection. It is, for a lot of people, when they get C. diff, they get it again within, it's like 4 to 6 weeks. I apologize, that might not be exact number, but there's the percentage of people who have a recurrent case of C. diff when they get it the first time is extremely high. And if you've ever known anyone that's had C. diff, again, it's an infection of the colon, and it is horrendous. It is, you are not leaving your home, or you are likely being hospitalized because you are having such gastric distress. And oftentimes we see it in older adults in nursing homes and long care facilities and hospital settings. And it's extremely contagious because it is spread through contact of fecal matter. And so you think about those facilities and it's easily spread. But in a home too, it could be easily spread, not properly washing hands or, utilizing the same bathroom in a home. And we don't want that for our patients. If they don't need the antibiotic, number one, right? And number two, there's other medications that can be prescribed to them instead. And so now, if a patient is allergic to amoxicillin, penicillin, again, ampicillin, what they are recommending, and this comes from the American Heart Association, it's ceflexin or azithromycin. They can also take clarithromycin or doxycycline. So all of these recommendations by the American Heart Association are readily available online. So these are not medications that I've come up with. That is certainly, I'm certainly not the expert on that. But the American Heart Association provides all of this in it's the AHA 2021 scientific statement on the prevention of infective endocarditis by Ordan group streptococcus. So that's the full title of it. But the table is right in there, but the American Dental Association also has it right on their website, and it's an abbreviated version. of what the American Heart Association has to say. But, really, really simple chart that can be followed. It has recommendations for adults and children and those that cannot take oral medication. And again, those that have an allergy. So, and you will see right on there that it says clindamycin is no longer recommended.
Yeah. So I think to wrap this up, we love our students here, right? This is our students and new grads are our future, and hopefully they're not going to have as many changes and stuff that we have had, but inevitably evidence and science does change, and we need to have a prepared individual for that. So I was hoping you could just leave us with a message for our students and new grads, giving them hope not to give up when things start changing all the time.
Yeah, I think the key is to be flexible and to recognize, right? I certainly wouldn't want my dental care providers to provide care to me the way things were done 100 years ago. And so being open to the fact that we are in a science profession and it is ever changing, and that is a good thing, right? So, and considering their source. So when you have a change in recommendations, your best source is not social media. So, I would really challenge you, if you see something or there's a concern, to go and look, what is the American Dental Association saying on this? What is the, American Dental Hygienists Association saying on this? Any association that you are a part of, where do they fall into this conversation? And then from there, you can even just kind of, Google is great, right? When you have a credible source. And so, utilizing credible sources to support the way you're practicing. And I really feel that that's the best way to ensure that it is up to date, because, things do float around on social media, and some of those conversations can be great, but they can be misleading too, and they may not be the full picture or accurate information. So knowing your source.
Thank you so much for saying that, because I constantly am talking to my students about practicing with evidence and finding the most current information, and is finding or being considerate of where you're receiving your information. So I think that's such a valuable point that you bring up. So thank you for sharing that.
I'm glad that's what you share too.
Yes.
So if people wanted to reach out to you if they have further questions, or if they want to maybe check out a course or anything that you're giving in the future, how can they find you?
Absolutely. So you can find me on the WaterPick webpage, so waterpick.com, or you can email me. So it's sscherer@waterpick.com, and that's WATERPIK.
And I'll put that in the show notes. So anyone, you guys can just go to show notes and click right through to it. It should open up in your email. So Sue, thank you so much for your time. I appreciate it.
Thank you so much,
Thanks
Sue.
for having me.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.